So good morning, Mr. President, and our very senior father in medicine, the erudite professor of neurosurgery, Professor Ohebulam, all the other senior members, executives, and founding members of the Nigerian Academy of Medicine, members that are here present, other colleagues here present, ladies and gentlemen, I have been invited to make a presentation. Right. I work as the health economist in the WHO Nigerian country office. But prior to my sojourn into the WHO, I was the founding health financing officer in the Federal Ministry of Health. So I set up the health financing team in the Federal Ministry of Health. So when I was asked to, by Professor Bekwet, part of what I'm going to share with you today perhaps might not be very exciting to you of the status of health financing in Nigeria. But towards the end, I have also tried to console myself a little because the work we have done in health financing in Nigeria over the past 10 years has started yielding some fruit, and with what the reforms that are ongoing, it looks like there is light at the end of the tunnel. So let me key health financing indicators in Nigeria and its impact on the health sector and the population. And I'm going to touch upon some political commitments and ongoing reforms, and I'll close with some key takeaways. Please take a little look at this. And this truly reflects what we have in Nigeria today, in the sense that we probably would have health care that would not be affordable by quite a lot of people. And as leaders in clinical health, this really resonates around us, because I'm looking at my father, Professor Hebulam, and I am hesitating to say some of the things I want to say, but you do not need to blame anybody. So I had one of our friends who had a spinal cord injury recently, and we took him to one of the private hospitals here in Abuja because that is the only place he could get the service that he needs to get. And he was asked to bring 18 million naira before they could go to the theater. But are you going to blame the neurosurgeon who is going to do the surgery because he had to import almost everything that he needs to conduct the surgery? So even though we believe that healthcare is available, but unfortunately there are people who are financially handicapped and they wouldn't be able to have those services. But health financing, we know, deals with all the systems, all the mechanisms, all the processes that are involved in accumulating finances, accumulating resources, pulling them together and using them appropriately. And at the end of the day, what we aim to achieve is universal health coverage. And what is universal health coverage is when services are available to those who need them when they need them, in the quantities and qualities they need them, so that they won't enter and Sorry, IT. Sorry, IT. Can you come and deal with this? Sorry, please. Are you moving it now? No, it wasn't moving earlier. Okay. Oh, okay. I point here. Okay. Very good. Central to all the sustainable development goals. Now, is it possible for us to look at universal health coverage towards achieving the SDGs as going to be achieved through 3 dimensions? And I'm laying this foundation so that we understand better where we are going to. And these dimensions include population coverage, service coverage, and financial protection. Now, taking a decision, political decision. But that political decision has to be taken based on the resources that are available in terms of human resources and materials. So if a country decides to cover all the pregnant women and children, a country also taking into consideration other segments of the population. And then in terms of the services, is it possible for us to cover all the services and say everybody will receive all the services free? I do not think that there is any country that really has been able to do that significantly. But countries like the UK, where you can easily walk in and walk out, also have some levels of restriction in terms of the benefit that those who walk in will get. Some levels of restriction, and the decisions taken to be able to cover what is covered is also based on resources that are available. Now, having looked at the 3 dimensions of universal health coverage, population coverage, service coverage, and financial protection, we know that to be able to achieve that, it truly depends on the choices we make in terms of health financing policy. And so, the health financing policies would depend on, number 1, the processes and mechanisms and systems used in raising the revenue. Number 2, the systems and processes used in pulling this fund together, and then what this fund is also. Then how we use them to achieve full utilization, financial risk protection, and quality of healthcare, including these days health security, is very important. COVID taught us a very bitter lesson that quite at the end of the day, if we put all of these things together. Now, how any country in health financing having a national dialogue on health financing that is led by the Honorable Coordinating Minister of Health and Social Welfare. And this conversation that we're having here today, we used the whole of last week to look at the whole of the health system in Nigeria, and then we had some very frank decisions in terms of where to go moving forward. Of course, we know that the funding sources for health can come from government. And here there is a global benchmark of 15% of government funding for health every year. And that is what is called Abuja Declaration. And then the such monies can also come out of pocket, and that should not exceed 40% of the whole of the spending on health in a country. Health insurance coverage should be up to 90% of the population that is covered, and 90% of the whole of the expenditure for health in a particular country. And then, of course, the funding can come from donors and then private sector, including philanthropy. Now, for Nigeria, we see that over the years, the investment in health and health sector has been increasing. But while that increment happened, we have found that significant. So, for data owners to finalize this, to have has been spent. So, by the report of those studies out. But based on what we know, we spend about 9 trillion in health, which is about $21.7 billion, about 4.6% of the Nigeria's GDP. This has been increasing. Again, the money that is spent per person per year also has been increasing. But like I said earlier, over 72% of this comes from private pockets, about 6.8 trillion. Part of what I'm going to do in the subsequent slides is not just to show us where we are in Nigeria. I did some levels of comparison with other 46 African countries that WHO support, so that you try to place Nigeria in a better way to understand where we are. So if you look at the slide I'm showing you, this slide gives us an impression of how important health is to every country. So the extent to which the expenditure on health is related to the gross domestic product of that country is what I'm showing you here. And you see where Nigeria is and where other countries is. In the whole of Africa, we see a country like Liberia doing better than Nigeria and some other countries, even though Nigeria has a better economy than those countries. And if I go to the next, which is how much Nigeria spends per individual, again, we see that there are countries like Seychelles, Mauritius, South Africa that are doing well. Of course, if you put Nigeria side by side South Africa in terms of our economy, so we will see that we probably do not match South Africa in terms of how much we spend per person per year. And this slide, we have those, that first slide, insurance coming from out of pocket. The graph that is flat is that predominantly over is from his insurance. In flying on top, then that is the day we will say, thank you, God, that we have achieved our aim in health finance out-of-pocket expenditure. Nigeria leads over 70%. Well, now, if I go to the next slide, okay. Okay, so the next slide is going to compare the countries of Africa and Nigeria in terms of social health insurance. And that helps us to see where we stand. Again, some other countries like Ghana, Gabon, Mauritius, Cape Verde, Rwanda are the ones that are leading the continent in terms of social health insurance. Can we have the slides back, please? And we know that with social health insurance, which is a form of financial risk protection mechanism, then there is a promise that people will not pay out of pocket, although very good. Okay, so it's working right now. Thank you. So, in practice, it is not a guarantee that if one is covered on health insurance, that will reduce out-of-pocket or catastrophic expenditure. But we know that it does. So that is why, looking at these countries, we see that Nigeria is also lagging behind some of the countries that we have mentioned earlier. But we have also done very well within the country to expand coverage on health insurance over the years. If I look back 10 years ago, specifically in 2015, when we had a landmark decision by the National Council on Health in terms of say that we have done well, because between that states in setting up each of the 36 states and FCT in terms of population coverage in health insurance. And for me, this is one of the things that I can look back and say Nigeria has done well, because these numbers that we are seeing here today, my colleagues in National Health Insurance Authority are here, and they are still doing so much to ensure that that expansion continues and accelerates. When we look at the funding or spending around primary health care, so we see that Nigeria is doing, the graph on my right, it looks like the expenditure on primary health care is not coming predominantly from government. It looks like that expenditure is coming more from other sources, especially private out of pocket. So Nigeria is doing well in terms of the percentage of primary health care of the current health expenditure. But when you look at the domestic general government expenditure, it is not looking too good. And then when we now, and this slide also tells us a lot about where this expenditure happens. Indeed, while we are spending more money on primary health care, over 82% of such funding on primary health care do not go through the primary health care centers. And you will agree with me, especially for most of our professors that are here that work in teaching hospitals, anybody who has fever will go to National Hospital. Anybody who has fever will go to Gwagwalada, or they will go to FMC Jabi, for those who are here in Abuja. But ideally, the first place that someone will go to for cases of fever and cough and the rest of them should be a primary health care center. And then if there is a need for referral, the person goes there. And that's the reason you are seeing this graph look like this. And I'm not sure this will change, except there is any decision that is taken to be able to reverse this within the shortest possible time. And then these monies that are spent are also not spent efficiently, because they are mainly spent around curative care. But even when we look at curative care versus preventive care, then the curative care goes more to communicable diseases like malaria. So you can see that over 49% of all the spending on communicable diseases go to malaria every year. And then we will look at some other priority interventions in health. COVID, TB, non-communicable diseases, HIV, neglected tropical diseases, malaria, reproductive health. They are all predominantly funded by the household. And for us, this is a lot of inequality. This is a lot of inefficiency in spending in health. Again, we look at 55% spent on infectious diseases, with malaria having the highest in all of this. But what is the impact on the health system and on the population? So here, we use what we call UHC, the Universal Health Coverage Service Coverage Index. And in the coverage index, we use 4 indicators. Number one is reproductive, maternal, newborn, and child health. Number two we use is in terms of capacity. Put together the whole of the UHC service coverage of Nigeria and other African countries, we see that overall, Nigeria lags behind all of them. But of course, when we look at those of non-communicable diseases and then service capacity and access, Nigeria is doing better. But when we look at the communicable diseases and then reproductive, maternal, newborn, and child health, Nigeria is not doing well. And that's why when you see the curve of maternal mortality, infant mortality, neonatal mortality in Nigeria, you see truly where the challenges of Nigeria is coming from. Can we have the slides back? So, from all that we have seen and our analysis so far, so it looks like some of these for reproductive, maternal, child and adolescent health and communicable diseases in Africa.